Hey, Paul, if I ever find that doctor that screwed up my limb, my limb replacement surgery, I'll kill him with my bare hands.
All right.
My
BEAR?
bare hands.
All right. Great.
Yeah.
Great stuff.
Yeah.
Nice visual pun for
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Life Memorial Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. I'm Dr. Matthew Franquato, here with my great friend and America's primary care physician, probably the primary care physician, Dr. Paul Nelson Williams. Hey, Paul.
Kind of. As always, say probably a primary care physician anyway.
This was an episode that you produced, Primary Hyperparathyroidism, with guest Dr. Lindsey Quo. And Paul, why don't you start us off? I mean, like where to begin with this topic?
It's worth it talking about the symptoms as an overview, Matt, just because in large part, they can actually determine whether someone not proceeds to surgery. There's a set of criteria for patients who don't have the classic symptoms, but I think that's a good place to start because I think we've all checked basic labs, then had the calcium come back borderline or elevated, and then if you've done the Williams technique, you repeated it, and then it's still borderline or elevated, then you're like, oh no, now what do I have to do with this?
Yeah.
So you're forced to address it, and 9 times out of 10, it's going to be primary hyperparathyroidism. For me at least, that's far and away the most common cause of this elevated calcium. Even though sometimes it normalizes the PTH, then we'll still stubbornly stay high. So it's from there. Once you confirm that with the labs, it's probably worth asking patients about symptoms because the indications to operate are the classic symptoms, and then there's a little bit more nuance for the symptoms that are non-classic, which we'll get into and I'll ask you about. But the classic symptoms. The patients that proceed right to surgery are the ones who have bone disease specifically. And by that, I mean things like osteoporosis or these brown tumors, which are these distinct radiographic findings, or fractures or kidney complications, which include your urinary stone disease and then also nephrocalcinosis, which I've never seen other than Google image searches and it looks gnarly. But then there's also a whole host of other sort of non-classic symptoms that are worth asking about once you've gotten to this point in your workup. So Matt, why don't you talk us through some of the things that you're now asking for now that we know better?
Right. Some of these make sense pathophysiologically, like you can ask about polyuria, polydipsia. Sometimes people have like constipation or abdominal pain. She said heartburn is another one. But the ones that she said that like she asked about like fatigue, dysphoria, maybe some people tell her they have short-term memory loss. These are not really things that I would have thought necessarily had to do with hypercalcemia. But she said in her experience, sometimes people will complain about these things when she asks about them and they will get better after the surgery. These are things patients may tell you or you can ask about. And while it's not going to necessarily, you're not going to send someone to surgery because they have dysphoria, you could still tell them that may be playing a part in it. This metabolic condition may be playing a part in some of the other symptoms that they're having.
Yeah, the multiple guidelines are kind of funny about the neuropsychiatric symptoms because like we can't promise they'll go away if you take out the parathyroid, but on the other hand, they might. So everyone's just kind of ambivalent about it, but it's worth asking about because if you do fix it, then you can be a hero.
But Paul, can I just blame all the mild hypercalcemia I see, 10.3, 10.4? Can I just blame it on a thiazide and call it a day?
I mean, you can, but you would just be a not great doctor, I guess, would be where I would start. No, it's interesting. So it's in terms of thinking about medications that can cause hypercalcemia, I think we all know thiazides are potential culprits for that, but they're kind of interesting. So a couple of things. If you're going to test that hypothesis, like there's a pretty long washout period. I think when Dr. Quo was talking about, she said something like 3 months of just having them off the thiazide before you can actually call it, which is way longer than I would have guessed.
I usually do a month, and that's just because I don't want to send them back to the lab the next week, but I would have thought a week would have been enough. So
yeah, same. The other thing that I thought was interesting as I was reading about this is that oftentimes, I think we've talked about this in prior episodes, the patients that have hypercalcemia that you attribute to their thiazides go on to develop primary hyperparathyroidism anyway. And they don't fully understand the pathophys behind that. There is they think, some direct thiazide activity on the parathyroid gland itself, in addition to some of the other, obviously, renal mechanisms of it. But in any case, you may still want to consider primary hyperparathyroidism, even if the thiazide is part of the picture. So there's the thiazides. Then the other medication that you should at least know about or think about is lithium, which can be a cause. Then there's some other ones, exogenous vitamin D and even vitamin A supplementation are sort of rarer causes of that, but not as common as thiazides.
Yeah, and from episode number 281, hypercalcemia, we had an infographic that I'll put in the notes for this one. But basically, you do the Williams method, you repeat the calcium. I would say 1 to 3 months, something like that. You can do, depending on how high it is. And then with that, I would get a comprehensive metabolic panel. So you get the albumin, creatinine. You can send a phosphorus with that. And of course, send vitamin D, the 25 hydroxy vitamin D. So that's not the active form, but it's the more stable form that we can sort of make more sense of when we check labs. And if the PTH is high, then that suggests this is PTH dependent hypercalcemia. And your causes we talked about, lithium can do it, primary hyperparathyroidism can do it, and the other big one is this familial hypocalciuric hypercalcemia. Paul, that one's easy, right?
Well, kind of. It's not easy to say, and it's not one that I think about, but that's one of the reasons why you're supposed to do the 24-hour urine calcium. And this is done to differentiate the hypocalciuric, so your urine calcium would be low in this case, versus the primary hyperparathyroidism. So there is this, I'm going to say it one more time, familial hypocalciuric hypercalcemia that is genetic. It is also entirely benign, and there's also no reason to take out someone's parathyroid glands when it's present.
Yes.
So it's really important to make the distinction because these patients have a slightly different set point. But other than that, they're not going to run into the same complications or the same problems. It is a benign condition, and you don't want to miss that and send this person for surgery when they do not need it. So that's why you're checking the 24-hour urine calcium to make sure that you're not missing that as a potential etiology of the patient's hypercalcemia.
Right. And then for patients that have a low PTH, you can stop thinking about primary hyperparathyroidism. That's where you're thinking maybe about the PTH-RP or, checking an SPEP, checking TSH, thinking about like malignancy and granulomatous disease, those sort of things. So, that's a whole different lane. But for us in this one, the big ones that the endocrine surgeons, they want to make sure, like once they're convinced this could be primary hyperparathyroidism, they just want to make sure that they're not going to take it out for if someone has FHH and they're, so that 24-hour urine will be done by them. I think, Paul, we agreed that we don't like to send the 24-hour urine because it does require a lot of coaching and it's hard for patients to do it correctly, even under the best conditions, which I cannot really provide. So I often will rely on endocrine or the endocrine surgeon to get that done.
And also, importantly, I don't want the patients mad at me. So I will have the experts have them do that test.
Yeah, fantastic point. Paul, one thing that I wanted to mention, because like when you see someone with high calcium and you think they might have primary hyperparathyroidism, my reflex has been to stop vitamin D. And Paul, would that be the correct thing to do, or is that a mistake?
No, same practice. I feel like for whatever reason, something had anchored my brain that you don't want to give patients with primary hyperparathyroidism vitamin D because you'll just send them into a horrifying death spiral, and then you never practice again. But it turns out most of the recommendations are these patients, if they are vitamin D deficient, should be repleted and maintained at a level of at least 30 nanograms per liter, which is I think the typical reference range for most people in terms of like
endocrine guidelines and 30 to 50. Yeah, that's most guidelines seem to say that.
I probably personally wouldn't go guns a-blazing with the high dose repletion. I still am a nervous enough person. I might check in with endocrinology just to make sure I'm giving the correct dose, but it's not something you should stop entirely. And these patients actually should be repleted if needed. Right.
Yeah, because one of the causes of secondary hyperparathyroidism is vitamin D deficiency. So you just want to make sure that you take that off the table by giving them a normal vitamin D. So if their vitamin D is less than 30, I would have them on a supplement. And that was practice changing for me because I've been doing things wrong. Now, Paul, once we've made the diagnosis, so we have the high calcium, we have the high PTH, what else do we need to do? We've made sure that their vitamin D level is at least 30. What else do you do for these people?
Yeah, if the patients have not had a DEXA scan at this point, that is probably the next thing that we should do. And one of the things that is recommended by the guidelines and by Dr. Quo is I typically, Matt, I think the DEXAs that I order get your hip and get your lumbar spine. I do not typically order a DEXA of the distal radius, which is recommended when you're working up primary hyperparathyroidism. That the distal radius apparently has cortical bone that is disproportionately affected by this condition, so you can get a better sense of how the patient's bone health has been impacted by their primary hyperparathyroidism. So DEXA scan, first and foremost, at those 3 sites is what is suggested by the guidelines, at least.
Yeah. And, I guess the other thing you could potentially do is just get like a plain x-ray of the wrist and see if there's, osteopenia, like low bone density based on just that, like just the eyeball test. Sometimes you can see that. And then for the vertebral fracture analysis, when I ordered it, it seemed to like break my healthcare system. The
Yes.
patient, I got all sorts of phone calls about it. So if you're really concerned for vertebral fractures, depending on where you're practicing, you may or may not get the DEXA with the VFA, vertebral fracture analysis. You might want to just order just films, x-rays, just plain x-rays of the spine to look for compression fractures. But in an ideal world, you would do DEXAs of all these sites. Paul, the indications for surgery, I think they've been pretty stable over time, but why don't we go through that? And we have a figure that you made to kind of remind people of that.
Yeah, obviously worth knowing, and at least talking to your patients about. So symptoms, as we talked about, are an indication for surgery into themselves. So specifically the skeletal complications. So if you would happen to find osteitis fibrosis cystica, first of all, good on you for finding it. I don't think I've ever actually seen it reported in an X-ray, but also fractures. And then the renal complications that you think about are specifically nephrolithiasis and nephrocalcinosis. And I feel like I mentioned this before. I've never seen nephrocalcinosis on imaging other than the Google image search, but it looks pretty gnarly when you look for it. And then chronic kidney disease is also listed as a potential renal complication, but I'm not sure that's really a symptomatic one. That's more along the sort of asymptomatic findings that might prompt you to send someone for surgery.
And Paul, did we mention, I can't remember if we mentioned already that the reason you don't see like osteitis fibrosis cystica and like these brown tumors and nephrocalcinosis as often as we used to is because we're now identifying these people earlier by this asymptomatic high calcium level.
No, that's a great point. Yeah. So the prevalence of primary hyperparathyroidism is increasing, but that's in part because we now offer calcium as a routine part of the labs that we check. And so we're sort of seeing patients before they develop symptoms, which is a good thing. It just means a more complicated workup in the long run for us. But we're seeing more hypercalcemia, and then also with more aggressive screening for osteoporosis, a lot of the times as part of your workup for that, you're checking a PTH, and that might come back elevated, even in the setting of normal calcium, which we'll talk about. And that may also prompt you down this particular branch of the algorithm in terms of talking about surgical options.
So, Paul, the other things, the asymptomatic reasons to surgerize somebody, what are those?
Yeah, so significantly elevated calcium, and that's defined as greater than 1 milligram per deciliter above the normal. If patients have osteoporosis by the DEXA scan that you ordered because you're a great doctor. If they have a creatinine clearance less than 60, and the reason being is that the presence of primary hyperparathyroidism can accelerate chronic kidney disease and you actually slow down the rate of progression if you correct it. Nephrocalcinosis or nephrolithiasis by X-ray, ultrasound, or other imaging. Hypercalciuria, which is not one that I think about often, but when you're doing your due diligence and actually checking that urine calcium, if it's greater than 250 milligrams per day in women or greater than 300 milligrams per day in men, that's an indication for surgery. And then younger age, which is always a little bit counterintuitive to me, but that just means if you don't treat it, they would be living with it longer, which puts them at greater risk for complications. So the younger you are with this, the more benefit they get if you correct it early on. So it does make sense once you kind of parse through that. But for me, I always had to sort of pause and think about it.
And we don't really have to order imaging for this because the surgeon is going to have an imaging test of choice, whether they want a SPECT scan or they want a 4D CT scan of the neck. And that's really it's not even necessary for our surgeon told us that her eyes are the best tool for identifying primary hyperparathyroidism in the operating room. But they do use the pre-op imaging just to kind of plan the surgery, which gland do they think is most likely involved. And also they will get imaging of the thyroid to make sure there's no thyroid nodules or you don't want to have to do more than one neck dissection if you don't need to, Paul. So they want to make sure there's no thyroid disease that needs a surgery as well before they take someone to the OR. So that seems like good practice.
Yeah. Yeah. The less slicing and dicing you have to do around the neck, probably the better off the patient will be. I think that's fair.
Yeah. And then I thought some of the post-op care stuff that we talked about was interesting. So if we're the primary care doctor, our patient goes for get their parathyroid glands out. Anything we need to be monitoring, and what does Dr. Quo do to make sure that the patients do okay?
Well, it sounds like blessedly the surgeons take ownership of the patient in the brief post-op period, which is nice. But post-operatively, I know Dr. Quo specifically sends patients home with a calcium taper, which is just a phrase I don't think I'd ever used before, because you do worry about post-operative hypocalcemia in the very short term. And in fact, she even counsels patients that they have symptoms of hypocalcemia to either take extra calcium or just head to the ER to get some labs checked. So if they have, I think specifically like perioral tingling or digital paresthesias, like those raise concerns, and those patients probably need a lab check and a little bit of extra calcium. Yeah, and I think that's the end of that sentence.
Yeah. So that's it. I mean, it's a surgery that works well. Like if your patients are selected and you appropriately, you make sure they actually have primary hyperparathyroidism, they can really benefit from the surgery. Paul, there's two other things I wanted to talk about, sort of related to each other. So there's normocalcemic hyperparathyroidism, and there's normohormonal primary hyperparathyroidism. So these are basically these sort of like, I think I've seen these both in my career because, you're like, oh, I bet you this person has primary hyperparathyroidism because they have high calcium, and you check the PTH and it's, quote, normal. Or they have high PTH for whatever reason. You found someone with high PTH, but their calcium is normal. Like, so talk us through these conditions and what do we do with these?
Let's start with normocalcemic hyperparathyroidism. So that, as you mentioned, Matt, like I feel like the setting where I see that is I'm doing the initial, I think exactly as you said, I'm doing the initial workup, and I'm convinced this is primary hyperparathyroidism, and then their PTH comes back elevated, but their calcium has down normalized. And you're like, ugh, what is this? So that probably is still primary hyperparathyroidism, but you have to rule out secondary hyperparathyroidism in these patients. So things like hypovitaminosis D, renal insufficiency can present with this. Even certain types of malabsorption can work with this. So if you have any question at all, this is a good chance to call in your endocrine cavalry and just make sure that you're actually managing the right thing. So it may be primary hyperparathyroidism, but it could also be the secondary, and that those are a little bit stickier, and those may not benefit necessarily from the parathyroid surgery. So those probably important to tease out with your local neighborhood endocrinologist. The normohormonal, and I can see why you left me with these, Matt. Primary hyperparathyroidism. This is where you have elevated calcium, but you also have like this normal PTH, and hopefully you hear the quote hands in my voice. The point being here is that if you have hypercalcemia, you should have a suppressed PTH. It should be low if your parathyroid is working the way that it's supposed to be working. So this normal range is still relatively hyperparathyroid, even if it's in the normal range, because it's supposed to be suppressed. And those patients, at least according to expert opinion, are managed in the same way that you would someone who has the classic primary hyperparathyroidism with the elevated calcium and the elevated parathyroid hormone.
Yeah, and we had talked about that on the first episode. I just don't think we gave it that complicated name, but it is, when you read especially the endocrine surgery guidelines, they do mention that. So yeah, I think I have a lot of cases like that in my panel, and I'll have to kind of revisit how I'm looking at those, and definitely I think get endocrine involved if it's one of those cases where I'm just not quite sure if I'm making too much of the numbers or not. So, Paul, let's get to some listener questions. And Paul, our first question is from Joshua Wilkins. And Joshua asks, I have several patients with significant adipose tissue of the upper arm. This gives their arm a cone shape. Blood pressure cuffs fit poorly since cuffs are meant to fit around the cylindrical shape. Do you have any suggestions for how to deal with this? Paul, I thought this was a great question for you since you are a blood pressure nerd and America's primary care physician.
Yeah, I'll give you my answer, Josh, then I'll give you what I found as I was sort of digging into this. Truthfully, in practice, I get the biggest blood pressure cuff I can find, including a thigh cuff, and I'll just do the best I can on the arm and like the shape. Just let the chips fall where they may. I'm not sure it's the most scientific way to do it, but short of an art line, you got what you got. I will say, as I was digging through this, I found a paper from the Journal of Clinical Hypertension entitled, Matt, you're going to love this, of funnel arms, Popeye, and other size challenges. This is from 2005 by this guy, Raymond Townsend, who actually references the guidelines that were present at that time. And he talks about, what he describes as a rogue anatomy of this funnel arm that you see in patients who have a lot of adiposity.
I love this guy, Paul.
It's I'll send it. We can include the paper. I'll send the paper, and maybe I'll even put it in the Discord. But he basically, long and the short of it is, he actually does a wrist measurement and then justifies it by saying that is actually okay by the guidelines. So he will turn the cuff 180 degrees to keep the rubber tubes from being a nuisance, since there is limited working space at the wrist with this technique. And then he does blood pressure by palpation of the radial artery. So it's a very complicated and sort of tortuous way that he actually measures it. And then he'll do a wrist measurement. This is, as a reminder, before in the days before we had the blessing to use the automated cuffs. Anyway, he references the 2005 guidelines at that time, which do say they do give their blessing at the time to do the wrist cuff measurement if you have to. I will say that the most recent guidelines do not give that blessing and do not mention funnel shapes or any of that other stuff. So I do the best I can with the automated machines. What's your actual practice, Matt?
Well, yeah. I mean, like you said, you got to make sure the cuff is big enough for the arm. Technically, we should all be having a tape measure measuring half the distance between like the acromion and the elbow, and then measuring the circumference of the arm, because then that will, on the cuff, it says like, this cuff is for arms 25 to 32 centimeters, right? So how are you going to get the circumference unless you actually measure it? Yeah. But I don't think most of us are doing that. You're just kind of eyeballing, is this a small, medium, large, extra large cuff, or do I have to go to like the thigh cuff or something for the person? So that's pretty much what I do. And I mean, the blood pressure guidelines nowadays have a lot of detail on how to measure a blood pressure. The KDIGO guideline was the one that I looked at just to see. They didn't mention anything about like cylindrical arm shapes, so no dice there. So thank you, Paul, for looking into it more. But I did,
crazy person.
I did put the figure in KDIGO. Just that it reminds you of simple things that you might forget about, like empty bladder, and having an empty bladder. And I always remember back supported feet on the floor, but it's hard to measure. Like there's the casual office blood pressure is what most blood pressures are, but we really want a standardized blood pressure, and that takes a little work to coach people to do that, and to coach your techs and everyone to do that. But we have one of those machines, Paul, in one of the places I work, where you can just put the cuff on and you press a button and it'll do 3 blood pressures. Mm-hmm. And we've actually got the medical assistants, they're on board now too, because they have to do. They're getting asked way less now to do repeat blood pressures, because they'll be like, put the cuff on people, leave the room, and they're getting better readings that way. So it's been great for the office if people have that kind of machine.
Yeah, no, my staff are great, but they also recognize that I'm a maniac about blood pressure. So it's still not unusual for me to do the repeat, even though they're doing stellar work. But I also had the capacity of the patient sitting for 5 minutes, whereas I don't think that they do. So it's there's a lot that goes into it.
So Paul, Jason wrote, and we don't have Jason's last name here, but Jason said, I'm curious about the process that goes into each episode. How long is spent research preparation, recording, editing? I know you guys always give a shout out to people who work on the episode, but I'd like to know more about what's happening behind the curtain, delivering all this knowledge food. So Paul, did you want to take any parts of that?
Yeah, a long time. I don't know. It takes probably at least 8 to 10 hours, I think, to put the episode together. And this is just, I think, not even counting finding the right guest and doing all the prep work and getting them set up so that they are prepared to actually work on an episode. I think just doing the research, writing the script and sort of organizing things takes me, Matt, at least probably a good neighborhood of 8 hours. A lot of that time is spent in pre-reading just to make sure that I'm covering the topics that need to be covered. And the post-production similarly takes usually at least 8 hours, but probably closer to 12 for me between putting together the graphics, the show notes, the CME. It takes. I'm a plotter, but then also there's just a lot to kind of put together. So it takes, I think, easily 20 hours per episode, and that's just not even counting like prepping the guest and finding the guest.
Yeah, I mean, I would have it in 15 to 20 hours is what I estimate, and what I sort of tell our team. But before the episode, sometimes I can write almost like all the questions just based on like I see it's something I'm relatively familiar with and I just know what I don't know about it. Other times I have to do a couple hours of reading, like some recent review articles. I'll make sure I'll look it up to date, see what they say. That way I know what everyone knows. And then I try to look deeper into the literature to find some more interesting questions. But yeah, so it takes time. Every step of it takes time. Show notes take 3 or 4 hours to put together. The CME questions an hour or two. The graphics are a couple hours. So yeah, it's a big undertaking. That's why we have a big team who does a great job, and that's why it can't just be me and Paul doing this thing. And we don't. We have there's a production company that does the editing for us, so we really just have to listen back to the episode and tell them, okay, we need edits, at this timestamp and this timestamp, but no longer are we physically editing or digitally editing this ourselves. All right, Paul, let's get on to picks of the week. So, Paul, I'll go first. My pick of the week is this a show you recommended many, many years ago, Killing Eve. I can't remember if I recommended this just recently. We've recorded so much recently, but I'm in season 3, and I think season 2 was weird, but I really have enjoyed the show. I think it's very good character development, very complicated relationship between, the titular character Eve and the assassin Villanelle. But the rest of the supporting cast is great, even as people come in and out of the show. And I would recommend it to people. Paul, any words about the show? I know you liked at least the first few seasons.
Yeah, no, I loved it. It's a shame. I don't think I'm spoiling anything by saying it's universally recognized they failed to stick the landing. Like, I think the finale is it was a missed opportunity, but otherwise, like, it's so well acted, so funny at times, and like like you said, the relationship between the two main characters is so fascinating that I thought it was great. So I enjoyed the vast majority of it.
All right, Paul, how about a pick of the week from you? Because that's what people really are coming here for.
Oh yeah, well, I'll name an album that no one will listen to, but so I'm gonna pick an album called "Ride the Wild Night." This is from Swami, otherwise known as John Rice. So Matt, I've recommended previously Rocket from the Crypt, one of my favorite bands of all time, and Drive Like Jehu, one of my other favorite bands of all time. And the frontman, not the frontman, but one of the lead forces behind both those bands, is this guy named John Rice, who actually is in charge of the Swami label, and he has his own album out. He's got a couple actually under the sort of Swami imprimatur called Ride the Wild Night that is just straightforward, like garage pop punk. It's a lot of fun. The choruses are sing-alongable. One of my favorite songs is I Hate My Neighbors in the Yellow House, and they're all pretty straightforward, like just straight ahead rock that has like great anthemic choruses by a guy who I respect and just think the world of. So if you're in the mood for something just sort of light and fun and just straightforward rock and roll, then Ride the Wild Night by Swami, aka John Rice.
How do you spell Swami?
Swami, and his last name is Reis.
Okay.
So he's actually the runner of Swami Records, for what it's worth.
Swami Records. All right, Paul. Well, let's get to an outro because we gotta let people go at some point.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
It's the first time every time. You can get our show notes at thecurbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox. This includes the Curbsiders Digest, which recaps the latest practice-changing articles, guidelines, and news in internal medicine.
And I wanted to give a special thanks to all of you, all our patrons, for your wonderful questions, for your support. We literally couldn't do this without you. Also like to thank our whole Curbsiders team. Our technical production is done by Podpaste. Elizabeth Proto does our social media. Jen Watto runs our Patreon. Krista Chu Manchu moderates our Discord. Stuart Brigham composed our theme music. And with all that, until next time, I've been Dr. Matthew Frank Watto.
And as always, I remain Dr. Paul Nelson Williams. Thank you and goodbye.